Hi, my name is Matt Harris. I'm a surgical resident in the UK and study lead for Podrick. I'm pleased to present our work looking at Bayesian in silico trials applied to obesity-related cancer prevention. This is a culmination of the Podrick project, which is a collaboration between Leeds Clinical Trials Research Unit and Manchester Cancer Research Centre funded by Cancer Research UK, where we aim to understand the feasibility of a large-scale clinical trial looking at weight loss to prevent cancer. Thank you so much for the invitation to speak here at the Society of Clinical Trials, and hopefully as a surgeon I'm going to be able to put on a reasonable performance to presenting to a room full of methodologists. So firstly I wanted to start with quite a bit of background just to help understand the rationale between such a thorough preliminary analysis. So in 2016 an IARC working group defined that there were 13 individual cancer types related to the presence of overweight and obesity. And obesity is now the second most common modifiable risk factor after smoking and is predicted to become the #1 cause in the next 20 years. And this has already surpassed smoking in some countries. So between 1990 and 2022, 89% of all countries in the world had an increasing prevalence of obesity in women and 73% in men. Essentially, we are facing a global epidemic of obesity. So as we predict the global burden of obesity-related cancers, even without considering rise in these obesity rates, we see obesity-related cancer incidence becoming an even greater burden on global healthcare, and therefore we want to consider the future of obesity-related cancer prevention. So firstly, we need to think about how can we treat obesity. There are three broad categories: surgical, behavioural, and pharmacological. So with surgery you get excellent long-term weight loss in the region of around 25 to 30%. With behavioural interventions such as diet and exercise, this magnitude of weight loss is much less, between 0 and 10%, and that falls off when you look into the long term. And with pharmacotherapy, historically this again has had poor efficacy. However, with the recent arrival of new GLP-1 drugs, this is a real opportunity to have some potential, with patients experiencing weight losses of up to 25%. So I just wanted to focus on a few of the pieces of evidence around some of these interventions. So there's good evidence that bariatric surgery reduces cancer risks. For example, in this meta-analysis there was around a 40% reduction in the risk of cancer after having a bariatric intervention. So firstly, we need to think about how can we treat obesity. There are three broad categories: surgical, behavioural, and pharmacological. So with surgery you get excellent long-term weight loss in the region of around 25 to 30%. With behavioural interventions such as diet and exercise, this magnitude of weight loss is much less, between 0 and 10%, and that falls off when you look into the long term. And with pharmacotherapy, historically this again has had poor efficacy. However, with the recent arrival of new GLP-1 drugs, this is a real opportunity to have some potential, with patients experiencing weight losses of up to 25%. So operation. Looking at lifestyle intervention, there is some suggestive evidence that behavioural intervention reduces your risks, and this is another really important study, which is a large randomised controlled trial of behavioural intervention versus control for diabetes remission. There was a suggestive 16% reduction in cancer risk, but this did not reach statistical significance, and this was theorised to be due to a lack of power. Intervention. So firstly, we need to think about how can we treat obesity. There are three broad categories: surgical, behavioural, and pharmacological. So with surgery you get excellent long-term weight loss in the region of around 25 to 30%. With behavioural interventions such as diet and exercise, this magnitude of weight loss is much less, between 0 and 10%, and that falls off when you look into the long term. And with pharmacotherapy, historically this again has had poor efficacy. However, with the recent arrival of new GLP-1 drugs, this is a real opportunity to have some potential, with patients experiencing weight losses of up to 25%. So looking at drugs, they've only been licensed for the treatment of obesity since 2021. Some observational studies have shown a reduction in cancer risk. However, there is some really methodological challenges in creating observational evidence for drugs, and we look towards clinical trials. Therefore, we have undertaken systematic reviews. We've not shown any change in cancer risk. However, we have shown that there is high risk of bias, particularly around the reporting of outcomes. So firstly, we need to think about how can we treat obesity. There are three broad categories: surgical, behavioural, and pharmacological. So with surgery, you get excellent long-term weight loss in the region of around 25 to 30%. With behavioural interventions such as diet and exercise, this magnitude of weight loss is much less, between 0 and 10%, and that falls off when you look into the long term. And with pharmacotherapy, historically, this again has had poor efficacy. However, with the recent arrival of new GLP-1 drugs, this is a real opportunity to have some potential, with patients experiencing weight losses of up to 25%. So if we think towards these interventions as are they feasible to reduce obesity-related cancer, bariatric surgery is not deliverable on a population-level scale. The efficacy and long-term efficacy of behavioural intervention isn't quite there either. However, pharmacotherapy do present a possible opportunity, which is why we undertake this analysis. And this has really caught the public attention. We presented some of our work around this at Malaga last week, which has hit the headlines in the UK. So we want to get to a future of policy and clinical management to be informed in an evidence-based way to reduce obesity-related cancers. The best way of doing this is probably to undertake a clinical trial. However, it's going to be very expensive, very complex, and also extremely time-consuming given the fact that we're looking at cancer prevention. So our project is centred around using in silico trials. So we're going to create a suite of in silico trials simulating weight loss intervention versus control, comparing the differences in interventions, control groups, trial designs, and ultimately we want to find out, is a trial feasible? And if it is feasible, how can we create one that is optimized for success? So there's three work streams that have gone into this, which I'll touch on very briefly before we get into our presentation today. Firstly, we have done a thorough literature review and taken our prize specifications for our in silico trials from real-world data, particularly from Globocan, and large interventional trials such as the SELECT trial, which is really important. This is a randomized controlled two-arm placebo-controlled trial with semaglutide versus placebo. We've also undertaken several systematic reviews and meta-analyses, as we've mentioned already. Our second work stream is around an expert consensus. We wanted to define the need for a clinical trial and narrow down some of our clinical trial design parameters. We included 60 experts from 9 countries, and we found that there is a pressing need for clinical trial evidence. We should be looking at effects on a generic population, and that we should be examining single specific intervention. And finally, that there was some research priorities, including understanding mechanistic pathways and identifying cancer precursors. Our third work stream, and this is what I'll be talking to today, is our expert elicitation of our one of our parameters. I'm going to talk about why we did this, how we did it, our results from our early in silico trials, and our next steps towards planning a real-world clinical trial. So before we get into it, I wanted to take you through the structure of one of our basic in silico trials, and this is our basic framework. So essentially, we take an intervention group and a control group. We have one simulation that each individual will be assigned a weight loss taken from a distribution that comes from the real-world data. So this distribution on the left-hand side that you can see is from the SELECT trial that I've mentioned already. Each individual's weight loss will then be assigned a distribution of probability of cancer incidence, and we want to come up with something like this on the left-hand side, and ultimately that will lead to a specific number of cancers developed at the end of the trial in the intervention arm, and then a specific number at the end in the control group. We then test for statistical significance between the two, whether they're in a two-arm t-test for p equals less than 0.05. We then simulate a large number of these trials, and that will then give us our Bayesian assurance, which is the proportion of our simulated clinical trials, once it's stable, that reach statistical significance. We then examine these across a range of sample sizes, which allows us to examine the efficiency and feasibility of that individual clinical trial scenario. And so this step is really critical. As you can imagine, it's the relationship between what your weight loss might be and what your risk of cancer is. However, it's really difficult to estimate this in the literature, so this is where we have taken further methods to understand how we can estimate this the best. So initially we undertook some basic simulation studies, and we set this as our extremes of plausibility. We found that our estimations using our plausible extremes cause a difference in assurance at a standard clinical trial scenario between 33% and 95%, and this highlighted to us that this was a really key parameter to try and estimate as correct as possible. So we wanted to try and do this systematically, but it was a really complex question, and we had the need to allow for qualitative discussion. So we settled on using the Sheffield elicitation framework, which is developed by the University of Sheffield, to answer questions like these, and you can find their website and resources here. So we chose 9 international multidisciplinary experts that had specific expertise on obesity and cancer. We undertook first an evidence review over 2 months, where all of the experts took time to understand the multidisciplinary evidence and highlighting other pieces of work to the rest of the team. We had training for 1 hour around understanding probabilistic judgments. We then undertook the first expert elicitation, which took 5 hours, a second which took 3 hours, and then we had 2 weeks of qualitative feedback, ultimately giving us our elicited quantity of interest. So we wanted to try and come up with something like this, so a continuous parameter but with some uncertainty either side. So at each individual weight loss on this continuous scale, you would have a specific distribution of the probability of cancer. So our quantity of interest, therefore, was the absolute risk of obesity-related cancer in a trial population with a theoretical 8% baseline risk when there is no weight loss, and the participants experience 10% weight loss. So we want to do this at 10% and also at 15% total body weight loss. And that should hopefully give us something like this. So these are the 2 studies that I highlighted at the start, the look ahead and the bariatric surgery meta-analysis. And essentially we're wanting to begin to plot pieces of data along this curve. So during the workshops, we asked our experts to set their upper and lower plausible limits, their median, their quartiles. We then visualised these distributions to the rest of the group and undertook some qualitative group discussion as to why they selected those parameters. Would you be interested in changing them based on the group's judgments? Experts then recalibrated their judgments and then undertook a single judgment from the perspective of a rational, impartial observer of the group, and this gave us our elicited quantity at that specific weight loss level. So from turning those 2 elicitations into a continuous curve, first we plotted our parameters, and essentially that gave us 5 points, treating them as data augmentation priors. We then simulated a large number of model parameter vectors. This then gave us a distribution by weighting each set of model parameter vectors based on their fit to our data augmentation priors. This then allowed for a curve looking something like this, with a mean and then 95% credible intervals around it. We took some qualitative elicitation feedback into account, the fact that there would be a plateau effect in real life, there's probably a threshold effect of around 5% weight loss, but also that this relationship is roughly generalizable to other baseline populations. So this gave us a relationship looking something like this. So it's a curve with a threshold, with a plateau, and with uncertainty around it through the middle, taking into account all of our data. And this would be individual probability distributions of uncertainty to visualize what we have created. So using this in our in silico trials, we mirrored the SELECT trial, which is again this 2-arm randomized controlled trial using real-world weight loss data. We had our primary outcome of obesity-related cancer incidence over 10 years with a baseline 8% absolute risk. So this is what our weight loss distributions look like. And this is what we found. So our assurance, the unconditional probability of a trial success given a true underlying effect, was around 51%, and this was a sample size of around 18,000. It looks like we reached this plateau of sample size increase on the increase in insurance at around 50,000 participants. So it looks like if we undertook a similar large-scale clinical trial like SELECT, our assurance for semaglutide may potentially be prohibitive. So we've then undertaken a separate elicitation using an alternative drug called tirzepatide, which has a higher efficacy of weight loss of around 20%. So we can see that we've quite impressively shifted that assurance up. So quite a lot of this model is driven by the absolute weight loss. And we've managed to improve this to around 89% at that 50,000 patient mark. So essentially, in conclusion from our elicitation on our early models, is that large sample sizes are required to reach high levels of assurance, but early simulations suggest that a trial like this may possibly be feasible. So next we're going to undertake expanded in silico trials, optimize some of our optimize our key considerations. We are undertaking an expert funder and trialist group to understand the relationship of assurance to feasibility and understand whether the appetite for funding a trial like this is there. We will be undertaking real-world data validation and, of course, include patient influence optimization of potential weight loss interventions, and ultimately, hopefully, progress towards a real-world clinical trial. So thank you very much to my supervisors and participants across the world, and of course to our patient representatives at Obesity Voices and the European Coalition for Patients Living with Obesity. Thank you very much. If you do have any questions, I'd love to answer.